Aneurysm of the abdominal aorta is the gradual dilation of the aorta, the heart's largest tube. It's like a balloon that you blow up. When it swells, the walls can become too thin and it bursts. When an aneurysm bursts, it's what we call a ruptured aneurysm. There is a 90% mortality rate, so it's extremely serious. Typically, men over 65 who smoke are most at risk of an aneurysm in the abdominal aorta. In this population group, between 5 and 10% of patients will probably have an aneurysm. But we follow the patients, and if the aneurysm becomes larger than 5 centimeters, we offer them a preventative treatment to protect them from the risk of rupture. For this endovascular treatment, we implant a stent, which only requires 2 tiny incisions in the groin area, so that it's only minimally invasive. Unfortunately, there is a cost in the long term, because minimally invasive treatment by stent graft requires a certain number of secondary operations after the first one, because there can be leaks, a problem with tightness, or physiological problems, because the branches of the affected aorta can bleed back or regurgitate into the sac. As of now, a follow-up is necessary and further operations will be needed to be sure we have completely embolized the aneurysm with the stent. Today, we are not able to prevent them. We do not have stents that enable us to avoid this kind of complication. The Kardiozis endoprosthesis is implanted via the groin by inserting a guide wire and its delivery system. The surgeon advances the delivery system under fluoroscopy in the aorta toward the aneurysm. Then, the surgeon partially deploys the endoprosthesis, which was compressed inside the delivery system. If necessary, he can adjust the endoprosthesis position so as not to cover the renal arteries. Once well positioned, Kardiozis is fully deployed and its legs are released. To anchor it to the aortic wall and prevent migration, the surgeon releases the anchor pins. This system alone is not enough to exclude the entire aneurysm. Extensions need to be implanted inside the arteries, supplying blood to the lower limbs, and are placed into the endoprosthesis legs. The surgeon positions the first extension under fluoroscopy and deploys it. To insert the second extension, the surgeon retrieves the previous delivery systems from the vasculature. The same procedure is repeated for the second extension, which is positioned under fluoroscopy so that the aneurysm is completely excluded. The delivery system and the guide wires are then retrieved from the vasculature, and the surgeon closes the incisions. Conventional endoprosthesis cannot prevent other aortic branches from supplying blood to the aneurysm. Kardiozis is different. Fibers around the endoprosthesis occupy the aneurysm sac and are in direct contact with blood. Blood naturally thromboses on these fibers. Platelets progressively clot on the fibers and prevent retrograde blood flow from supplying blood to the aneurysm. Once clot formation is over and the aneurysm is thrombosed, pressure decreases and the aortic diameter returns to normal. Fibers around the endoprosthesis occupy the aneurysm sac and are in direct contact with blood. Blood naturally thromboses on these fibers. More and more patients think they are treated and cured when they have a stent. And in fact, not only are they not treated, they are also not cured because the aneurysm continues to grow in size. The aim of this device is precisely to reduce the follow-up, to avoid secondary operations, and avoid later risk of leaking or rupture, which are not very frequent, but they do exist. So the aim of this device is precisely to reassure the patient by telling him or her, we have inserted a coil to stop your aneurysm with fibers that will embolize it. Also, you will need less follow-up, fewer scans. You won't have to have one every 6 months. You'll have fewer Doppler scans and fewer follow-up visits. Less radiation, because CT scans expose you to radiation. So what's very interesting in the concept of the Kardiozis stent is that it creates a physiological reaction. It's the fibers on the external wall that, on contact with the blood, will coagulate the blood. So there are no drugs and no more treatment required. It's a mechanical reaction, so it's very promising.